This is not you. No. There's plenty of seats in the front. They don't cost extra.
Yes, but are they unnecessary here?
I always think I should like tape some sort of special prize underneath the seat in the front. You reach under. So we're very excited today to have two really expert voices on the subject of innovations in care and cost. I'm just going to take a moment to introduce them and kind of embarrass them with their accomplishments, and then kind of just set us up for the discussion that I hope we have. Dr. Arnold Milstein, or Arnie as he insists I call him, is a professor of medicine at Stanford and directs the Stanford Clinical Excellence Research Center. The center is a collaboration of the schools of medicine, engineering, and business to design and test new healthcare delivery models that both lower per capita healthcare spending and improve clinical outcomes. And they've seen some unicorns as well. His career and ongoing research is focused on acceleration of clinical service innovations that improve the societal value of healthcare. He serves as the medical director of the Pacific Business Group on Health, the largest regional healthcare improvement coalition in the U.S. He also guides employer-sponsored clinically based innovation development for Mercer Health and Benefits, and chairs the steering committee that directs the largest U.S. physician pay-for-performance program. He also served as a congressionally appointed MedPAC commissioner for several years. And then Dana Mead is joining us today. He's from Kleiner Perkins, and he's a partner there. And he works primarily in the life sciences practice. Is that right? He leverages experience accrued from his venture-funded startup management roles and board participation to support entrepreneurs and innovators dedicated to making a real difference in the lives of millions suffering from life-limiting diseases. For the last 3 decades, Dana's career has focused on identifying new medical technologies, developing new markets and therapies, and building world-class management teams. He's worked with physician thought leaders around the world representing 12 medical specialties. And before joining Kleiner Perkins, he was the president of Guidant Vascular Intervention, a fully integrated billion-dollar division with more than 4,500 employees. I want to thank you both for joining us. I know you're both very busy people, so. Hospitals and doctors, as we all know, are facing a lot of heat these days to clean up their act. Medicare is beginning to penalize them for high error rates, hospital-acquired infections, and preventable readmissions. Then there's the accountable care organizations that are supposed to start to force them to care about cost and quality, and at least that's the hope. These converging pressure points, incentives the economists call them, are beginning to have a surprising effect on the kinds of new medical devices and investments that Silicon Valley venture capitalists are looking at. VCs are finding they can't sell new whiz-bang technologies to hospitals if they're really expensive and add to the complexity and thus the error rate of delivering medical care. In response, VCs are investing in entrepreneurs who dream up oftentimes less sexy and more pragmatic solutions like IT-enabled services and preventing so-called never events. Health system experts say a change in America's medical innovations pipeline holds long-term promise for reining in costs. So we're going to talk about today. So I want to start with Arnie Milstein. And Arnie, can you just sort of paint us a picture in your mind of when you look back over the last, say, 20 or 25 years of the VC pipeline, what you have seen historically come out of that pipeline and what that means for delivering care, particularly in a hospital setting?
Sure. Well, I think the best anchoring point is what was happening in America's health insurance market over that time. And in the beginning in 1985 and really through for the next 15 years to about 2000, the insurance companies and to a lesser degree the Medicare program through so-called Medicare Plus Choice, which was the predecessor of the Medicare Advantage program, was sending out, was basically trying to move money toward doctors and hospitals that could generate more health with less money. And it was a time when the venture capitalists who I had a chance to work with, and I'll throw in some of the private equity investors that investing larger quantities of money. Their interest was at that point dual. It was in so-called managed care solutions. IT was not far enough along yet, so that those who invested in IT back then, generally did quite poorly. But there was still a very robust market and a lot of interest in biomedical innovations, be they pharmaceuticals devices, there was still a very strong market for those. And then, there was a time, actually not inconsequentially aided and abetted by some healthcare journalists, where attempts to manage, particularly cost of care, became unholy and unpopular, and managed care was demonized. And so, the beginning of this was United Healthcare announcing that they were going to stop arguing and fighting with doctors and hospitals and just, I'll paraphrase this, start writing larger checks, which was quite popular with the doctors and hospitals. But over time, created some major societal problems, which then accreted, over the next 10 years, resulting in in what we now have, which is both a public and private sector. Public is represented by the Affordable Care Act. Once again, getting much more interested in more health with less money, and if you think about how you do that, there's only two choices. You either can speed up what's called translational efficiency, which is the amount of time before something that's better and cheaper is discovered and when it's widely adopted, or you can speed up knowledge turns, the discovery of new things that might enable healthcare to be both better, and cheaper. And in the venture capital community is, because they have short time frames for, they're limited partners. They don't want 25-year returns. They want their money back in 4 to 8, or worst case 4 to 10. And so they don't, for their venture capitalists are extremely sensitive to shifts in the in the surrounding market. And obviously, while all this was going on, the FDA was getting meaner and meaner, and getting tougher and tougher on, especially on 510K approvals of medical devices, which is a shortcut many of you are probably more than aware of. And so if you look at kind of any portrayal of where venture capital money is going across the 4 primary healthcare categories, what you see is, over the last, if you just look at, I just recently went back and looked at 08, 09, and 10 in the first couple quarters of this year, and what you see is indeed exactly what you would predict given those societal shifts, which is there's been a decline in device and pharmaceutical investing, perhaps a little bit of a sign of a turnaround in some of the 11 numbers. We don't have fourth quarter numbers in, but while that's going on, a steady increase in the amount of money being invested in the other two things that might have a little better chance of reducing costs and improving health, which is healthcare IT and healthcare services. And so that's, as you think about the societal shifts that are, surrounding the healthcare industry, I think the shifts in venture money are become understandable. And so that's in broad brush, what I see. Maybe.
Great. We'll pass back the microphone. And just ask Dana to sort of expand on that. A couple of days ago, I was down in Silicon Valley at Venrock, which is another venture capital firm similar to Kleiner. And it's interesting, you walk in and you see, I think going all the way back to the 1930s, because it's a Rockefeller company, basically, if I'm getting that right. But it's more interesting when we start to look at the 70s and the 80s and the 90s, and every year they would put a little tag for every company that they had invested in. And it was interesting, you could sort of see the shift that Arnie is talking about kind of on the walls. As it went from, medical devices, biotech, into now in 2006, 7, 8, some IT, more health IT, so on and so forth. So I wonder if you can talk about, from the VC's perspective, what are you, obviously you're wanting to back products or companies that you can actually sell into, to hospitals and provider groups. What are you hearing from hospital administrators and others about the kinds of cost pressures that they're under and what they want from you now, what they want from the venture community now?
Sure. First of all, I was remarking to Arnie how remarkable it was when you asked this group to move from one side to the other. If you had done that with the physicians or venture capitalists, it never would have happened. So it was very impressive. So what are we hearing from the end user? And we're also hearing from a different end user now than we did 10 or 15 years ago, and obviously that's the healthcare consumer. As all of us play a larger role, we're burdened with a higher percentage of the cost in healthcare. healthcare consumers become a very important part of that whole ecosystem. That 15, 20 years ago, we listened to the doctor, we did whatever he or she said. Now we come well armed with information. We have access to information to actually impact that. We're paying more from our own pocket, so we have a greater interest in that. And we now are starting to understand what are the choices we have from therapies, et cetera, with physicians. So that's certainly one change. Another change we see is it is getting harder for many reasons. The hospitals, just like managed care maybe did years ago, they basically slowed down the process. So everything in a hospital to get a product approved and get it through the approval committees into a hospital takes much longer than it did. So the way we would translate that into our industry is the sales cycles for the companies selling product into hospitals is much longer, more difficult than it has been historically. And it's the hospital's way to kind of slow down the incoming scuds, right? If you slow down the new products coming in, your spending on new products invariably are going to be slowed. Another phenomenon that's happening, and it's interesting, Yogi Berra said it's deja vu all over again. We're seeing it now in hospitals, where hospitals are employing physicians again. And we see it first in this high-cost specialty areas like cardiovascular and orthopedics. You're now going to see it in primary care, where foundations and physician networks are formed in order to bring these physicians together to do things like you're talking about. To be able to build an accountable care group, you have to have some level of control over how patients or groups of patients are treated. So what happens when the hospital employs the cardiologist, what they say is we're spending X on all our medical supplies, those stents, implantable defibrillators, all those different products. If we're able to reduce that by X percent, we will share a percentage of that reduction with you. Amazingly, the cost of those products come down. They're willing to use one company's product. Historically, the cardiovascular physicians as well as orthopedics have great power in hospitals because cardiovascular, orthopedics, and oncology makes up about 150% of the profits in hospitals generally. So they have great power and they're able to use, quote, physician choice products. So if I wanted a company's defibrillator, I wanted a company's stent because of the power I had to move my business to another hospital. I had a lot of leverage in the hospital. That's starting to go away, of course, as the physicians become, quote, employed by the hospital. So those are the three dynamics, the entrance of the patient into the dialogue, the hospitals employing physicians and the physicians being part of the solution rather than just part of being the problem, and then the way the hospitals are slowing down the processes to introduce new products into it.
And what you're talking about, of course, depends on large enough numbers of hospital administrators sort of getting that the game has changed. And Arnie, I wonder, obviously, you sort of look at this across the country. Are these just early innovators or hospital CEOs who have seen the light, or what do you see sort of across the country in terms of how many hospital administrators are really not entering the medical arms race, but are instead reacting to these kinds of pressures?
Particularly if you reflect on the last 2 or 3 years, there are really two things happening simultaneously. First, you have these payer wins beginning to tilt back toward, I won't say back toward, let's call it tilt toward value, meaning quality divided by, or outcomes divided by cost. That's one factor, and it certainly would drive hospital administrators if they're going to say, if I'm going to participate in a Medicare hospital bundled payment pilot, I have to think about ways I can now reduce the cost of my production, and one of the ways you can do it is by as Dana laid out, being much more selective about what I buy and slower in the new things I buy. And then the second thing that was happening is, remember, the economy was tanking. And for those of you who are not familiar with the time relationships between the economy declining and when hospital demand begins dropping, there's typically about a 15-month lag. Because a lot of people, they still have jobs, they still have benefits. In fact, a lot of them start using the hospital more, during that until they, lose their jobs. There's sort of an anxiety about that, and so that's a second reason, why what Dana is describing is going on. So it's the bigger trend, and also just the what hospital administrators at this point are clearly know, which is that once the economy declines, particularly in a profound way, very soon after, demand for their services is going to decline. And then you throw in, the fact that enabling the uninsured to get health insurance doesn't start till 2014. So you've got this period where you're not really being helped, and more people are out of work and therefore uninsured.
Yeah, not a lot of company trips to Maui at that time. Yeah. Well, I guess what I'm trying to get my head around is, on the one hand, we have this sort of medical arms race going on, and we've been talking about the Da Vinci robot a lot today. And Arnie has a very funny sort of, the robots are invading. You said this to me on the phone the other day. That was a very funny image. So we have, on the one hand, this medical arms race. We have in, Los Angeles, as you have instructed me, hospitals building these massive towers that they've never really been able to recoup. And then, on the other hand, these kind of tremendous cost pressures. And I wondered, Dana, can you sort of make sense of that for us? And as reporters, how do we figure out which trend is dominant or ascendant? And it seems somewhat schizophrenic sometimes.
Sure. Well, I think the arm race you see in the hospitals is really driven, and it's all driven by economics. And I think what they're trying to do is select certain layers of the patients. So obviously the well-insured, a lot of patient-paid procedures, and they're competing, quite frankly, those hospitals, if you look at what they really compete around, it's those three areas that I talked to you a little bit about before. It's oncology, very broadly, with large cancer centers. That's orthopedics, where they're building large orthopedics. A lot of, if you look at Stanford, they have a large outpatient orthopedics, and as you listen to the radio, so it's all the stuff you hear on the radio. And the third area, of course, is cardiovascular medicine. And so if you look at the ads that appear in the Wall Street Journal and other things, it's usually in those three specialty areas that people are focused on, because those are the most profitable areas. The population, obviously, we're all affected by those three areas. And so that's really the focus. And then it's to create an environment where people will go, and then they'll have the word of mouth, and they'll talk about their experiences. So they care more about what I would call the patient experience. So 10 or 15 years ago, they weren't quite as focused on that. Now they're very focused on the patient experience, and in particular around those three areas that I just outlined.
But Arnie, can you talk a little bit about how, your raison d'etre really is this value equation that you keep coming back to. And it does seem like it's difficult to evaluate whether or not some of these acquisitions are done. They're done for marketing purposes to a certain extent. They're done for patient experience, as you say. But at some point, somebody pays, right? Because Medicare is not going to reimburse the hospital for the new robot. So ultimately, when I go then with my private insurance, it seems like I never voted for them to buy the robot. So can you talk a little bit about that?
Sure. Well, I think one of the challenges of I'll call it the consumer-directed healthcare movement was this whole problem, which is that all the money is being spent by very sick people who blow through their spending accounts in about 10 seconds. So it's that obviously is not proving to be proven to be as robust a cost reducing method as was envisioned. And so you've now got this interesting phenomenon where one element of the Affordable Care Act, if it's not undone, could make a very, very big difference among the so-called profitable patients. That means non-Medicare, non-Medicaid, in terms of their level of I'll call it cost consciousness. And that is something that has been, the popular term of which is the Cadillac tax. That comes online in 2018. It is fundamentally an excise tax that either the insurer or the self-insured employer or the consumer, depending on who's buying, is going to have to pay for any amount that's in excess of a level of growth in health care premiums starting last year that is far below historical rates of increase in health care spending. And it's a 40% tax. And if it's allowed to stand, what it's going to do is it's going to cause all of the people with commercial health insurance, which is where hospitals' profits come from, to begin to much more actively gravitate toward health insurance plan options that are more economical. How do you make a health insurance plan more economical? There's a limited number of choices, the most powerful of which is to begin to narrow or limit your network to those hospitals and those doctors that are generating more health with lower per capita healthcare spending. That trend will, as it's going to begin to affect, the people who run health insurance companies and self-insured employer benefit plans far in excess of 2018. As 2018 approaches, the people who are responsible for these payer organizations are going, January 1, 2018, I'm imagining that if we don't, we're going to start seeing migrations into these lower cost plans that are much more selective. They want hospitals and doctors that are kind of the equivalent of a Toyota Prius, and so I think it's going to begin to affect hospital interest in Da Vinci robots, though not for biomedical innovations that are 100% clearly life-saving. I mean, those will, people will pay the price, and it'll be very hard for insurers and insurance companies not to pay the price. But there's a whole lot of biomedical technology innovation that does not meet that criterion, and the uptake of that both by hospitals and their ordering by increasingly accountable doctor groups who are trying to be part of a health insurance plan option that doesn't have a high excise tax is going to change substantially.
Dana, I wonder, in that world, if it comes to exist, do you see a role, or what role do you see for VCs? What kind of products or companies do you see VCs backing that can essentially help the hospitals start to save money? I mean, it seems counterintuitive in a way that you would have to spend money to save money. But what do you see are the kind of business opportunities in that new world that Arnie just laid out for us?
Sure. As Arnie reflected, in the National Venture Capital Association just did a survey of 156 venture capitalists who represent about 92% of all the investment in life science venture capital. It really reflects a lot of what Arnie said. And so they said, what are our biggest challenges? Well, number one is the FDA. Number two is CMS being reimbursed. Number three are larger economic trends that was mentioned. And what does that mean from a venture capitalist? How would we react to that? In addition to some of the factors we talked about on the hospital side and some of the challenges they have. So what's really happened is there's been less investment over the last 3 years, as Arnie mentioned, in biopharmaceuticals, so biotech pharmaceuticals, and devices, and more into diagnostics, more into life science tools, like machines that do sequencing. We have a company, PacBio, that does that, and more into healthcare IT itself, and what I call IT-enabled healthcare services are areas where the money's starting to shift. Now, why would that happen? Because Arnie mentioned, if you look historically at healthcare IT compared to investing in either pharmaceuticals, biotech, or devices, the returns for the top firms, we return about 4x what we put into a company, and the device biopharma only about 1x in healthcare IT over the last 20 years. If you look at that's for the top quartile firms. So why would we now be interested in healthcare IT? My last two investments are IT-enabled service companies. One is to make hospitals. So basically what it does is real-time asset tracking. So it tracks all the equipment in hospitals. It uses a Zigbee mesh network that's throughout the hospital. It tracks patients. It tracks doctors. Then it has a software analytics layer on top of that that helps with workflow and all other things that you could think about. Someone is, exposed to some type of infectious disease, we can tell you within a minute every single person that person interfaced with, every place they were in the hospital, etc. This takes weeks now to go through records to do that. Another company we invested in is a company called Teladoc, which is telemedicine. So we're going to have all these new people insured. Most of them don't have primary care physicians. When they get a cold, they go to the ER. That costs an insurer $720 every time they walk into the ER. So those type of companies that are doing it the right way, all within the regulations, we think are very interesting investments now that we would have never looked at 3-4 years ago for that. So the one challenge we've got, and Arnie knows better, you're going to be able to do a lot of consulting over the next few years, because no one knows what these ACOs are going to look like, or accountable care delivery. They don't have any idea what these exchanges are going to look like, both the commercial and the private exchanges. And so it's a little bit like heading into Y2K for these people. So they're trying to do a lot of things. No one knows exactly what it's going to look like. So they're doing things like trying to get arms around physician groups, trying to understand their own costs better, trying to be more efficient within hospitals. So there's a lot of that going on. So as an investor, I look at all that and I said, boy, it's really hard for me to do a device unless I know that device is going to improve mortality significantly. It can't just be a lifestyle improvement as much. I have to have more clinical data to support that with the hospital. That's just at the hospital level. That doesn't count CMS and the payers. And one thing our firm has changed dramatically, we never focused on payers in the past because we said if we made a product that was a good product, we always do the clinical work, and it saves lives and it improves lifestyle, the payer will eventually pay for it. But now we have a partner now that comes from the payer world that just helps us interface with payers. So we're spending all our time with Highmark and Regents and all the other Blues and United. We spend more time with them than we do with people that are coming up with new technologies because we need to figure out how to get our company's products paid for. And we need to understand where their head is because it's going to be important.
And is there, just to follow up on that, I was talking to one entrepreneur the other day who has a company, she's based in Utah. She's the one that makes these, it's called Catheter Connections. They make a catheter that has antimicrobial properties to it. And this is a product that sells for 50 cents. And she said she went to a bunch of VCs, and they all passed because they said that's not a price point we're interested in, even though unless you sell a lot. But talk a little bit about, is the VC community having to sort of step back from saying, these are products that can sell for $1 million, $2 million into a hospital versus a high volume product that's much smaller that kind of gets at patient safety issues, for instance, maybe something you would not have even entertained a few years ago?
Yeah, patient safety, obviously we try to make any of the products we develop as safe as possible for patients, but talking a lot about what's happening in the hospital now with never events and the fact that hospitals are actually getting punished, where if some of those events happen in their hospitals, they just don't get paid for all the time and effort and resources it takes to solve that problem that they've created. So there's been a lot of talk about that, and there's been a lot more focus on pharmaceuticals and biotechnology focused on infectious disease, etc. But it really hasn't, from an investment point of view, the kinds of things we're seeing in hospitals are more things like discharge technologies, because there's a lot of data that shows if you discharge the patient appropriately, there's a much better chance they're not going to come back quickly. And it improves outcomes dramatically. We've seen a lot. We have a company that has a wireless patch that a patient that's a heart failure patient, that we try to predict that cascade that results in a hospitalization. We also put the patch on them after they leave the hospital because 28% of heart failure patients come back within the first month. Very expensive for the system. And in the future, the hospital will be penalized for that. They won't be able to code for that. A lot of them do comorbidities and other ways to get around it. But there's a lot of those type of things that I think people are looking at. I've seen very little specifically to the never events. Now people are putting more tracking devices like I talked about on patients so you know where they are. A lot of those never events are falls. The patient gets up in the middle of the night, they're tethered, all this stuff. They're not supposed to get out of the bed to go to the bathroom, but they want to do that. And so there are people that are putting technologies like that together. But most of them, we haven't seen a lot of really interesting businesses yet doing that.
Okay. And this is at our national conference a couple years ago. When did we have Peter Pronovost? Is that 2 years ago? Talk to us, of course, about the checklist. And I wonder, Arnie, if you can talk a little bit about, you speak often about how many of the ways that hospitals control costs and control these never events are just sort of common sense approaches that are not necessarily a business model. Can you talk a little bit about where you see other, since we know, and I know you know Peter's work better than anybody, but why are these common sense approaches not rolling out across the nation as quickly as possible?
Well, there are really two reasons. Number one is if you look at where the economic incentives are, while it's certainly true that at the margin they're now, I'll call it small financial consequences that are linked to quality of care, such as the never events policy. Little point of history, I was the one who surfaced that for Medicare in the MedPAC meeting when I first started at MedPAC before people told me not to be so crazy. And none of the other commissioners were interested in it. They said, Arnie, it's a cool idea, but this thing ain't never getting through Congress because you have no clue as to how powerful the hospital lobby is. But what I didn't know is that Bill Thomas, who at that point was chair of Ways and Means, but his staff member was in the audience, nor was I particularly aware of the fact that he was a about to retire from Congress, and therefore was much less interested in what the hospital lobby, might think about this. And he made it happen. And so it's, I'm a great believer in it, but if you today look, from the perspective of a hospital administrator, certainly the direction is beginning to tilt a little bit more toward quality, readmissions and infection rates, and Medicare beginning to move, ever so gingerly, into tying Medicare revenues that they pay to hospitals into to quality. But the preponderant, emphasis is on cost, reducing cost. And so that's, we have to expect that that's going to be the preponderant preoccupation of, both hospitals and the doctors who work for them. I wanted to remember, there's one aspect of your question I think I'm not addressing. Please, get me back on track here.
Well, maybe just pop this over here first. Yeah, I guess the question is, for so many of these things, like a checklist, for instance, require nurses washing their hands and changes in behavior. Yeah,
exactly. Here's the, first of all, I'm a great supporter of the checklist. I think it's a brilliant idea. But here's the problem with I'll call it, with such ideas, is that anything that presupposes that humans, be they healthcare workers or patients or in any industry, do what you tell them to do, is substantially limited, if not doomed in some cases, right? Humans don't like to be told what to do, and it works really well in command and control environments like the military. As you begin to move away from command and control environments, humans like to have a lot of autonomy in how they go about doing their work, and so. We would have virtually no complications in American hospitals if all the policies and procedures that were written down and accreted over the last 30 years were actually followed, but they're not followed. And so what's the nature of the opportunity is really, once you've got something that's a terrific idea, like the checklist or washing your hands before you go into the operating room, these very good policies and procedures. I think the future really lies with technologies that can begin to make it easier for people to adhere to a certain workflow that's known to both improve quality and efficiency. And so playing off of Dana's example of these RFID chips that can begin for the first time to tell a hospital manager where hospital staff are and where patients are at any given point in time, and their proximity to one another. It, for the first time, enables kind of the visualization of flow, through a hospital, and then the distance from that to creating what we call an afferent loop. So that's an efferent loop. It tells you what's going on, what your flow is not that distant. We have technologies now that could begin to more actively prompt doctors, nurses, me, to say, hold on a minute, remember the checklist, Arnie? you're skipping over it. There doesn't seem to be a nurse watching you put in that central line, which is part of Peter Gronowost's brilliance, is that it's the social psychology. You don't just tell doctors to do it, but you get a nurse watching the doctor to do it. I mean, that's a very critical. And so a piece of RFID technology can say, hey, Arnie has just gotten one of these central catheters out and is approaching a patient for whom there's an order for a central line being put in, but there's no nurse within 100 feet of him.
Beep, beep, beep.
That's the way in which technology can substantially improve both quality and efficiency. And I think we are, it sounds Orwellian, but I think we are gradually moving into a world of what I'll call sort of orchestrated workflows done in psychologically sensitive ways, so people don't feel they're being commanded by some creation of Aldous Huxley or George Orwell. It'll be done with psychological sensitivity, but I think that's the direction we're headed. And as long as people who manage hospitals really make it clear that what this is all about is avoiding the kind of horrific consequences that are that never leave the consciousness of any healthcare worker once they've happened on their watch, I think they will be accepted. And so.
You know, one thing on that, just to note, is, I mentioned now hospitals are competing on, the technology they can provide, the procedures and the services and the environment they provide for patients. Two other areas they're going to be competing on much more because of this educated consumer I talked about. One is outcomes. Mm-hmm. And as you know, a lot of that data is already published, especially on things like CABG, heart surgery. And the other is going to be quality measures. And I sit on the quality committee of a hospital, and we talk about that a lot. And we do publish those data on I think we're up to about 20 different things that we measure within the hospital that we publish on the site that the hospital has. So if someone's interested in looking at that data, comparing that data to someone else. So I think a lot of the visibility into these measures, and there's a lot of people doing a lot of work, Arnie's helping support a lot of that I think is extremely important. And so I think that if it gets exposed more and there's more visibility and transparency, I think those things will start to happen naturally, and then the hospitals will be looking for solutions. This tracking system I mentioned also has this hygiene component at the sink that tracks and knows if someone washed their hands or didn't wash their hands.
And is there a report that's
generated? There is a report that's generated. One of the challenges is physicians, for some reason, don't love to wear those tags. To your point a little bit earlier. So I think now that's easy.
They speak out for their lunch.
That's right. It's easy to, yeah. They watch too many of those TV shows. But, it's easy to put it on an IV pump, or it's in nursing is more open to doing it. And physicians in some hospitals are doing it, and it will happen. It has to happen to do some of the things that we just talked about.
I'll ask one more question, then if folks have questions, we'll spend the last 15 minutes doing that. In fact, this is sort of where I end up with a lot of this is it seems like a lot of the investments, a lot of the potential for investment right now is in these sort of worker productivity tools. And one of the companies, one of the entrepreneurs I was talking to said, they, in thinking of their business model, they had to have this whole sort of army of nurses to deploy their new technology into the hospital. And I wonder, does that diminish the returns, or is the investment community willing to sort of take on not just worker productivity but sort of behavior change? Is that something you feel like you have expertise in, or?
The big holy grail left, obviously, in medicine is behavioral change. So it's adherence, compliance, as Arnie talked about within the hospital environment. It's the same with any, whether it's a pharmaceutical or it's a device or it's your glucometer or whatever you're using. If people used it the way it's intended to be used, the way it's prescribed by a caregiver to be used, we would all be in a better place. I heard Rod Epstein from Medco comment that so if a patient starts on Lipitor, at the end of 1 year, less than 50% of those patients are taking any Lipitor. Not just they're taking fewer than they should be, taking any Lipitor. So these are patients that have obviously been diagnosed with cardiovascular disease. I'm not talking about people that are taking it preventatively. These are people that truly have high risk for cardiovascular disease. So there's a real problem there. So we've really spent a lot of time on this, and we've spent a lot of time with Procter & Gamble. They have a lot of research on consumers, and they've also done a lot on healthcare consumers and trying to figure out how to motivate people. And our firm does, we're an investor in Twitter and Facebook and firms like that at Zynga. And so we know quite a bit about communities and social networks. And so we're trying to apply that knowledge and the whole knowledge of gaming and how incentives cause people to buy hundreds of millions of dollars of virtual goods every year, on Zynga. So we're trying to apply that. We also have a large mobile practice, and we have an iFund and different things we do there. So we're trying to think of how immediacy of having something with you all the time can impact that behavior. We're also looking at social groups and how your family members and your friends influence your behavior. We know who you live next door to, and a lot of other things influence your behavior now. So we're trying to look at all that together and figure out a way to truly influence that. What we found so far is all of us are influenced differently. So it's very hard to put us in groups. And it takes a lot of data. It takes all those things I mentioned. It probably takes a call center. It takes a lot of other things. You need coaching and counseling through that. So we're looking at models on how you can get that done. And especially, obviously, for chronic diseases and other things. But even just, exercising more, watching your diet more. So we're looking at ways to utilize all these new technologies. I would say so far we've failed at that. It's just very hard to point to any of those technologies or services because we know, for instance, a heart failure program. If it's carefully managed where the patient, just reports their weight, someone calls them on a regular basis to check in with them, that works. It's just to get that done, it just doesn't happen. Incentives aren't right yet to do that. So that behavior change to me is the holy grail. Because if you think about it, about half of what happens to us is kind of genetically coded to some degree. Another half is environmental, depending on the and stuff that we have control over. That's the part that I think is one that we're definitely focused on. We want to find investments in that area. It's just hard.
Well, I have one.
You do?
Yeah. I've always thought there should be an iPhone app that's a shaming app. So you do
Shame.
something that you're not supposed to. It just screams, shame on you. Yeah.
I have a wife that does that.
I have a 4-year-old that does that to me, yeah. So let's take some questions. What do you guys want to ask? Yeah, over there.
If I heard Ian Morrison right, one of the things he said, he was talking about hospital competition and talked about a zero-sum game, which made, and I didn't get to him later. I thought, has something changed? Because it used to be hospital competition meant you double the supply, you double the demand. It was more and more and more. Is the market changing to where if one hospital has whiz-bang new device, the other one isn't necessarily going to do it because they don't think they're going to create the demand to support it?
Who wants to take it?
I'm happy to start with that. I think, first of all, I do agree with that to some point, that you will see hospitals that are not going to succeed, and you're going to have some hospitals that are going to do even better. I think the ones that are going to succeed are the ones that are really going to have a clear identity on who they are and maybe more importantly who they're not. So I'm on a board of a company, a hospital that treats very high acuity, very sick patients. They are not good at treating someone that's not super sick because their cost of care is very, very high. And so on the flip side, it would be very difficult for a hospital that didn't have the level of sophistication to compete with them. In fact, they never would be able to do that. So I think what you're going to see is you're going to see the hospitals that have these unique capabilities, whether it's the ones that have a Zeus or have this cardiovascular capability, they will go out and provide those services to hospitals that can't afford to do those services. They'll never be able to have a critical mass of cardiac surgeons, or they can't have their own cath lab or whatever. And then I think what you're going to see is you're going to see other hospitals, first of all, will go out of business, or they'll be acquired and brought into these networks. And they'll perform different services. I think the number of fully integrated hospitals that do everything well in the future, I think that's going to diminish greatly. And I think the hospitals will become more specialized. And I think hospitals will continue to consolidate. Because in order to provide care, there are going to be more people that are going to look like Mayo, more like Cleveland Clinic, more like Kaiser. Because they're going to have control of not only the bricks and mortar, but also the physicians around that. I think that's going to have to happen.
Arnie, did you want to answer?
No, I think that
Okay.
go on.
Another question? Yeah, Lisa.
Lisa Alvarez from community. What about the hospitals, the standalone hospitals in communities where there's not so much rural hospitals, but my hometown is in northern Michigan. It's the only hospital for 100 miles, and it's called the Regional Medical Center. Those are hospitals that still do everything. There's plenty of those around. What about those hospitals?
Well, they aspire to do everything, but and I think as the pressure for lower per capita spending and better outcomes continues to build, based on these longer term trends and for we can get in, and also just to prevent the kind of societal divisiveness that occurs when you've got healthcare that's so expensive that only a small segment of society can benefit from it. I think we are going to start to see some of these geographically isolated hospitals that have been able to sort of write their own ticket, find life much more difficult, because I think you'll start to see insurance plans that are priced more favorably, so there's lower excise tax. And one of the conditions of being in the plan is that unless it's a life and death emergency, you don't stay, you don't go to the quote-unquote rural regional center for your cardiac care. You go to a place where it has much higher volumes and does it much better and much cheaper. So I think that the example you cited has been, they have had a nice, long, good ride, but I think if you look at sort of the bigger societal trends that are going to begin to shape the incentives that doctors and hospitals are going to face, those hospitals are going to start to shrink and begin to not provide all as many services as they do, but sort of begin to, I wouldn't say revert to primary care centers, but begin to focus on kind of the uncomplicated facets of hospital care, which are actually can be done much more cheaply and with equally good outcomes at less sophisticated places.
Yeah, Bruce.
Softball question. What's a Da Vinci robot?
What's a what?
What is a Da Vinci robot?
So a Da Vinci robot, actually a company I work for, started the company and the technology went in. And basically what it is, and it started, originally it was going to be for heart surgery for CABG. And basically what it is, it's a robot that sits on top above the patient. So think of it and holding a bunch of different tools. And they started trying to work through very small ports or trocars. And so the idea was it took out all the trimmer and things that surgeons have. And they're admitting they have that. So, so it was a sophisticated way to do that. And actually the surgeon was in the room, in the OR with you, but sitting in front of a panel. And on the robots, those tubes that were into the patient were 3D cameras. And so they were looking at a 3D camera, have their hands on some, like, think of joysticks, and actually they fully operate the tools. But for every little motion they could go. So rather than just the degrees of freedom that a human hand has, you were able to get even more degrees of freedom.
And you could probably scale it so that you could do more and more micro stuff until finally you could operate on an atom.
Pretty much. So what happened with those was they started cardiovascular, and it just did not work well for cardiovascular. So it was kind of a technology looking for a procedure, and that procedure was prostatectomy. So that has made the company, and now they're looking at, I could give you a long list of other procedures, but that, because of the sensitivity of the nerve beds you're working around there, when you're working on the prostate, became very important to people. And then it became a marketing tool for hospitals. And it was a way that these hospitals that were at some risk were able to differentiate themselves. And it's remarkable, even with these very difficult economic times. If you look at Intuitive Surgical and you just pull up an analyst report or two on them, they're doing incredibly well right now. It seems like they're almost defying gravity, but really hospitals still have a large appetite for the equipment and programs. And another reason those get bought is if you have a great surgeon at your hospital and he or she says, I need this to be here, I'm going to go somewhere where I can get this kind of equipment, it really puts the hospital in a difficult situation. And now the robotics for knee repair, and there's robotics for hair replacement. And the gentleman, the founder of Intuitive, is a close friend of mine. Fred Mall is a physician, and he started 4 or 5 other robotic companies, some more successful than others. They've happened to find with Zeus, Intuitive has a great application for the technology. Some places it's technology where you don't need it. That's one where it works.
I would like a robot to clean my dishes.
That would be a good thing.
Any other questions? Well, I know we're at the end of the day, so maybe we'll end a few minutes early and let everybody sort of mill about. But just wanted to thank you both so much for taking the time and talking with us. And if you have any questions, you can come up afterwards. I'm sure they're happy to hang out for